this angle here. And I'm going to come up under. Okay. So here, very slightly high on the left, very slight, okay? So left ASIS is high, okay? That's the left. And what I'm seeing in supine right now is the left leg is appearing long, okay? You guys see that? Now we'll do a long sitting test. Come on up. You okay with that?
We just did it this way at the clinic, but you want to come all the way?
Oh, you need to come all the way up.
Okay.
Yeah, because otherwise you got to get the pelvis to rotate. Yeah. Yep. Go ahead and go back again. Did you guys see a difference?
It's still long. Looks still long. I
Long
didn't see a
still looks
difference.
long.
I
Yep.
didn't see a difference.
I don't think I saw a difference either. Come on back up. And this is the other thing. The test, if they come up squirrely like that, it kind of invalidates the test too. So I'm getting a negative long sitting test. I'm not seeing anything dramatic here. But again, it's not a great test as a standalone test anyway. You checked the leg barriers on her, so you found
hamstring tightness and on the right abduction on the right and external tightness on the right.
Okay, all right.
On the left.
Okay, all right, that's fine. So did you treat those? Did you work
Yes,
on those all?
yes.
All right, good, good. Okay, so let's go over just some of the symptom reproduction tests, just to go over those for you. The model that I would use in the clinic, I don't do these. Do you do the symptom reproduction tests?
Which ones are those?
The Faber.
Compression, distraction.
I don't do compression distraction very often, once in a while. But I do Faber a lot.
So, yeah, and we'll talk about this in lecture. We'll talk about, there are actually different studies that talk about different clusters and which tests are more, have better diagnostic power than others. But again, they all have to be clumped together. But just as a review, go ahead and lie on your back. When we're doing a distraction and a compression test, did I teach you guys a compression test in side lying? So when we do a compression test,
We did cross.
we can do it across. We can also do it in side lying where we're just pushing straight through. So go ahead and lie on your side.
Matter of fun?
At this point, we're good. I'm just for demonstration. But if you're going to do it through here, you're going straight down through the iliac crest. So just straight down, that is your compression test. Okay? And then go ahead, and I would do the other side as well. And, yep. You're okay with that?
No? Yeah, no pain.
No pain with that. Okay, good. Okay, go ahead and lie on your back again. And then what I can do here, you're okay with that. No problem whatsoever. Okay, no issues. Faber test, you guys remember the Faber test?
Mhm.
Relax your leg. You're all right?
Yeah.
Okay, and then let's do this one. Relax.
Yeah.
Oh. Pain where?
My concordant pain. I mean, the pain
Okay.
that I'm feeling, yeah.
That is the pain. Okay, so there you go. That's a positive Faber test. So a positive Faber test means she's getting pain in the SI area, all right, in her case. But if you have to ask if they have a positive Faber test, where is the pain? Because it could be positive for hip capsule tightness, or a hip joint problem, or it could be a SI joint. So pay attention to that, okay? We're also going to do a thigh thrust test. Do you guys remember that? Did I teach that? Yeah. Thigh thrust test. So I'll come on this side. I'm going to get my hand under the sacrum,
Oh, yeah.
and I'm going to push down.
That just
Okay.
looks like it was very problem.
What?
It just looks like if you had pain in there, it would kill that test.
Let's find out. Let's see. Excuse my behind here. All right, relax everything. I'm going to get it a little under. So my hand is right under her sacrum.
Only a little.
Okay. You have to make sure when you do this, you're putting some effort into it. So, some.
More as you press harder.
Okay. So that's positive. Okay. We have the Ganslin's test. Do you guys remember that one at all? So that's basically we're torquing the SI joint. So I'm going to have you scooch off. Actually, let's do this side first. So I'm going to bring her into hip extension on one side, hip flexion on the opposite. No problem here. You're good. Okay, good. And then let's switch sides.
And you're testing the opposite leg, the one that's flexed?
Yeah, but when you document, when you do this test, you do it on both sides. And what I would just say, it's positive with left hip flexion or right hip flexion, whatever. Whatever the one is flex is usually the one that I would say that's the positive side.
Okay.
You're okay?
There's a little something there, may just be
Okay.
not the same pain.
All right. So far, she's got 3 positives, though. And the other positive, the other test, and I forgot to do this, is a sacral thrust test. So back in the dog. Lay flat. And all I'm doing here is I'm just, there's a bunch of them. There are a lot more tests we can do, too. Any pain with that? Okay, so CPR on the sacrum. Don't die on the sacrum. You're okay. Okay, good. All right. Now, what I want to do is I'm going to look at her sacral position, okay? So what we're going to do here, I'm going to pull this down. The sacral sulcus. So to find the sacral sulcus and the ILAs, can we get back to that PowerPoint? Just, Kath, just press right at the P on there.
Do you find that some therapists ignore the SI joint
Yeah.
altogether?
Well, there are a lot of doctors that ignore the SI joint. So there are a lot of different camps with regard to SI joint stuff. There's the camp that says, well, there's only 2 millimeters of movement that happens in the SI joint. So how much pain can that really cause? Okay. There used to be the camp that said the SI joint doesn't move at all, and that's old. Now we know that the SI joint does move, and I think in some people it probably moves more than it does for other people. But I think when you guys are out in the clinic, I mean, how many of you guys have had mostly orthopedic evals, right? How many of you, did you guys do any SI evals? Did you have people that, and what kind of methodology were they using? Was it more of a symptom reproduction methodology, or was it mixed? So this is the other thing. And then I think this is an important fact, or this is important. I think you can have sacroiliac joint inflammation, okay? And if that's the case, your pain provocation tests are probably going to be positive, okay? Now, can you have inflammation in an SI joint without an asymmetry? What do you think? It's a synovial joint. Could you have a sacroiliitis? Yes, you could. You could have a sacroiliitis without having any asymmetry at all, okay? There could have been some trauma that injured the ligaments. It could be something that's, it's a synovial joint. You can get arthritis in that joint. So I think that the symptom reproduction tests are positive when there's some underlying inflammation going on. That's what I think. I see a lot of patients that have no sacro. Julia's coming in. She says, "I have SI pain." Now, the other thing is this: if they have sacroiliitis or inflammation of the SI joint, usually where they're going to feel the pain is inferior to the PSIS. And you know, your palpation isn't necessarily going to give that away. It's the patient will give it away. They will tell you, "I feel it here." And they point to it like this, versus most patients with lower back pain, they do this. They say, "I have pain here." They put their whole hand on their back and they say it's here, or they say it's here. But when they can come and pinpoint, it's right here, you should be thinking, is there something up with the SI joint, okay? Is it inflamed, or is it just out of place, or is it both? That can happen too. But I have a lot of patients that I see that have lower back pain. They just come in with lower back pain, and they present with sacral asymmetries. Their SI joint doesn't hurt, but their sacrum is out of alignment, okay? So what is that? Why would their lower back hurt if their sacrum is in a right-on-right torsion? Yeah, it's going to wreak havoc on L5. What's it going to do to L5? Okay, think about your disc patients, okay? I mean, and I don't know if we even know who these disc patients are, but, you know, could a long-standing sacral torsion affect those annular fibers of the disc? Why not? You're in rotation. You're creating a rotational kind of force, or strain. So it very well could. So I guess here's where you get my biased version. I try to always be as objective with you guys as possible with regard to different techniques and things like that. But I think I do have a bias, and this is just where my clinical experience comes into play. I've had a lot of very good success in treating lower back pain patients using an osteopathic approach where many other treatments have failed, and you get the patient on their stomach and all of a sudden you start seeing things that most other therapists who never really looked at the SI joint would start to see. So you can think of this as, you know, do your McKenzie eval first, or your TBC kind of eval first. If they fall into any of those classifications, great. Or if they fall into a McKenzie classification, great. If they don't fall into one of those classifications, then don't forget to go down this road, because you might be very surprised at what you would see, okay? So when we go for this, when we evaluate the sacrum, again, I'm looking at the depth of the sacral sulci, and I'm looking at the position of the ILAs. I want to know which sulcus is deep, and I want to know which ILA is either posterior or which one is inferior. Now, if we have a right sacral torsion, what might my findings be? A right sacral torsion. I don't know if it's a right or right. It doesn't matter. I don't.
Left
my findings will be the
sacral
same,
sulci
right?
is deep and right is posterior.
Left sulcus is deep and
Right is
right
posterior.
ILA is posterior. Boom. Good job. Excellent. Good job. Okay. So that's something you might see. If you see a deep sulcus, okay, you want to think about, okay, is this ILA on the opposite side posterior? Or is the same side of the ILA inferior? And that's something else we haven't really talked a lot about. But we talked about sacral torsions. The other thing we didn't really talk about was sacral shears. And we'll talk about this in class too, but when we're dealing with sacral torsions, we're looking at a sacrum that's rotated, okay? With a sacral shear, we're dealing with a sacrum that's side bent, all right? Now, if a sacrum is side bent, it's either sheared downward or it's sheared upward. It's stuck up or it's stuck down. The findings are going to look exactly the same. The sulcus will be deep on one side, but now we have same side findings. The ILA will be inferior on the same side. Okay? So what we're going to do after I demonstrate this, I'm going to have you guys, we're going to break up a little bit. You guys are going to do innominate evals, so just check the innominate positions on each other, and then we're going to look at sacral positions on each other and just see. Catherine and I will come around and make sure you guys are palpating where you should be palpating with that. But when I look for the sacral sulcus, you really shouldn't look at a sulcus over somebody's clothes. I can't see it over their clothes. ILAs, I usually do over their clothes. I don't pull their pants down to see the ILA. But I usually get in here with my fingers, my fingertips, and I would say, okay, well, to me, that looks like the right sulcus looks deep. Okay? I would not argue with that. Do you guys see that? Her right sacral sulcus is deep. Here's how I find that. Again, her PSISs are here, come down and medial to them. So that is a deep right sulcus. Okay? Now I get under here, and I'm going to look at the ILAs. And is one more posterior than the other? Well, what I feel on Julia is actually she seems like she's a little bit more inferior on the right. Okay? So if you look at the sulcus here, this one, or the ILA, this one appears a little bit lower. So what I have now are what we call same side findings. Something is positive on the right sulcus, so right sulcus is deep, and the right ILA is inferior. Okay? You guys got that? So you're either going to look for, and we'll make a thing here. If the right sulcus is deep, we have three options, okay? Let's just say the right sulcus is deep. The ILAs could be even. That would be weird, but there's a reason for that. The right ILA could be inferior, or we might expect to see the left ILA being posterior, okay? Those are the things, and I'll put that on the board. Think that's what you're looking for, okay? Now, let me just ask you guys this question, though. Why would somebody, or might somebody, have a sulcus that's deep, but ILAs that are completely even? Any thoughts on that? What could be going on with, because you'll see that, too. It's not L5. Any thoughts?
If it's not on an axis,
Could it be like a conjunctival?
That'd be an anomaly.
so it's rotated and twisted or something.
It's usually a pelvic innominate, a posterior innominate rotation. So if you have an innominate, a posterior innominate rotation, let's just say, the sulcus could appear deep on the side of the posterior innominate or the inferior PSIS. Does that make sense? So that could do it. If the sacrum is malaligned, the ILA and the sulcus will be off. one can't be off without the other being off. So if one is off and the other is not, it's probably coming from an innominate dysfunction. All right, you don't have to worry about what the innominate dysfunction is, because that's not how you diagnose it, but it's probably coming from something other than the sacrum. All right?